So in my previous video, I had a look at hypokalemia, and so I decided to piggyback off that video and continue and do hypokalemia. If you haven't watched that video, I will leave a card tagged right here. Head over and watch that video before you watch this video, otherwise this video will not make sense. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at hypokalemia. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to receive notifications of such amazing content every time I post. Drop a like, drop a comment, and let's go. So remember that the normal concentration of potassium is between 3.5 to 5.5 millimoles per liter or milliequivalents per liter. An increase in potassium concentration above 5.5, we call that as hyperkalemia. A decrease in potassium concentration below 3.5 is known as hypokalemia. Remember that potassium is a very important cation that is found in the intracellular space. It is very important because it helps in actually maintaining action potentials, or rather membrane potentials of different types of cells. Remember that hypokalemia is relatively common and symptoms are going to be arising because of two things. Either someone has a very low concentration of potassium, that's less than 2.5 millimoles, or someone has a rapid decrease in the serum concentration of potassium. So it's very important to note that the severity of hypokalemia is proportional to the degree of the hypokalemia itself, as well as its duration, whether it's acute versus chronic. Patients that have moderate hypokalemia, that's a concentration between 2.5 millimoles to 3.5 millimoles, generally are going to have lethargy, weakness, leg cramps. Those that have severe hypokalemia less than 2.5 millimoles per liter may be associated with rhabdomyolysis, with subsequent renal failure, as well as respiratory difficulty and impending respiratory failure. Consequences of hypokalemia most often go unnoticed, but it may be associated with increase in risk of cardiac arrhythmias, especially in those patients that are on treatment with digoxin and those patients that already have pre-existing heart disease. Causes could be divided in the following things. It could be spurious, or what we call a pseudo hypokalemia, or potassium which is falsely low, diminished intake, redistribution, for example, potassium tends to move into the cells, extra-renal loss, this is usually associated with preservation of renal potassium, and renal losses which is associated with acid-base imbalances. We'll begin with spurious hypokalemia or pseudo hypokalemia. We see this if someone has a very high white blood cell count and blood that has been drawn from them, and then you leave it to actually sit at a room temperature for too long without actually running the sample. So the potassium can actually enter into the white blood cells, and this will cause the levels to be falsely low when you actually interpret that or run that test in the machine. Patients who have just received insulin, remember that insulin is going to help drive glucose into the cells. Glucose will be metabolized to ATP, and this is going to help drive the sodium-potassium ATPase pump and cause a lot of this potassium to shift into the cell. So this actually changes the concentration by about 0.3 milliequivalents whenever you draw blood just after insulin has been given. You may have a decreased intake, for example, those that are fasting and starving, those that are alcoholics. These are often also going to be associated with hypomagnesemia. Even those children that are malnourished, they may have some hypomagnesemia, such that when you are replacing potassium in these individuals, make sure that you do replace magnesium as well as those that have eating disorders. It may be due to redistribution hypokalemia, where their transcellular shift, a lot of these potassium is moving into the cells, and you get a lot of a decrease in the serum potassium. It could be associated with alkalosis. This is very common in the emergency department. Remember, this is a response to the hydrogen potassium ATPase. Remember, whenever there's acidosis, you have a lot of these hydrogen ions hanging around in the bloodstream, so they're going to be taken into the cells, and or rather alkalosis. There's very few hydrogen ions in the bloodstream that are going to be taken out of the cells in exchange for potassium that goes in. So remember that alkalosis, most of the times, even the disorders that are causing this are going to be associated with potassium redistribution in addition to them having a depletion in the total body potassium. You may have certain drugs that are going to increase the activity of the sodium potassium ATPase, beta-adrenergic agonists. The drugs like salbutamol, terbutaline, and these medication, and even things that can increase the sympathetic tone like the myocardial infarction, head trauma, even theophylline toxicity. In patients that have received insulin, such as treatment of DKA, remember that even though you are treating DKA and you take your ABGs and you do your serum electrolytes and you realize that the potassium concentration is initially normal, you still are going to give this patient potassium during the process of management, because generally when you correct the acidosis, the potassium is going to be driven into the cell. Even when you give the glucose and the insulin, potassium will be driven into the cell, and this person will start recording low levels of potassium. Other causes of cell entry include drugs like risperidone, cesium, quetiapine, hypothermia, barium intoxication, chloroquine intoxication. You may have extra-renal causes. Remember, these are things that are causing you to lose potassium, but not from the kidneys. So if you actually check the levels of potassium that are excreted from the urine over 24 hours, it's less than 20 milliequivalents. And if you just measure the concentration of potassium at any point in the urine, it's less than 30. So these causes may be divided into GIT losses, things like diarrhea. Remember, you're losing bicarbonate, you're also losing potassium. So these patients get a metabolic acidosis that's associated with hypokalemia. You may have chronic laxative and enema abuse, vomiting. This is a very common cause in the emergency department. Nasogastric suctioning, malabsorption, enteric fistula, villus adenomas at the rectosigmoid area. You may even have sweat. Remember that excessive sweat is going to be consisting roughly of about 9 milliequivalents per liter of potassium. This could be in the background of heavy exercise, in the background of heat stroke, even in the background of fever. In terms of renal potassium losses, these ones are losing a lot of this potassium in the urine. It's more than 20 milliequivalents over 24 hours, or if you get a spot urine potassium, it would be greater than 30. It can be associated with metabolic acidosis. Think of things like renal tubular acidosis, type 1 if it's affecting the distal part, type 2 if it's proximal, a DKA carbonic anhydrase inhibitor therapy, ureterosigmoidostomy, and then you may also have hypokalemia associated with metabolic acidosis. Remember that almost always hypokalemia is going to be associated with metabolic alkalosis. So you have this excess bicarbonate, which is going to be acting as a poor reabsorbable anion, and it's going to be carrying more sodium to the collecting tubules, leading to more potassium being excreted. Remember that as more sodium reaches these collecting tubules, potassium is always excreted at the expense of sodium. Same thing is happening with these things that are causing aldosterone to increase in the bloodstream. They're going to be causing primary and even secondary hyperaldosteronism, and it causes reabsorption of sodium. This is at the expense of potassium that is lost in the urine. You may have hypokalemia that's not associated with any acid-base imbalance, such as patients that are recovering from acute renal failure, those that are post-obstructive diuresis, even those that are taking loop diuretics. Thiazides are common causes in the emergency department, even those that have osmotic diuretics. So any drug that can actually, or anything that can actually increase the load of sodium actually reaching the collecting tubules, resulting in the excretion of potassium. Other causes include hypomagnesemia. Remember, if you have a case that is resistant and you're trying to treat the hypokalemia, it's not working, address magnesium as well. Even if magnesium concentrations are normal, you still want to give some magnesium. So hypomagnesemia is actually present in up to 40% of the patients with hypokalemia. You may have those that have acute leukemias and lymphomas, those that have hypothermia. It could be accidental or induced. So this ratio actually helps you determine whether it's going to be a renal loss of potassium or an extra-renal loss of potassium. It's not so useful in the emergency department, but it can actually help you in exams and also figure out whether this is a renal loss or extra-renal loss. It's known as the transtubular potassium gradient. So you simply get the urine concentration of potassium divided by the plasma concentration of potassium. You get an answer there. You divide this by the urine osmolarity divided by the plasma osmolarity. So if you get a concentration that is greater than 4, it means that you are losing a lot of this potassium in the urine. So this is being secreted in the urine. If you get a concentration that is less than 4, this is most likely that the losses are outside the kidneys. Same thing with urinary potassium. If it's greater than 20 milliequivalents per liter, it means most of the potassium is being lost in the urine. If it's less than 20 milliequivalents per liter, most of the potassium is being lost elsewhere. Remember clinical features here. Common findings are going to be things like weakness, fatigue, constipation, polyuria. You may have ileus as well as respiratory muscle dysfunction. You may group the clinical features according to the systems that are involved. For example, in the cardiovascular system, you may have hypertension, orthostatic hypotension. You may have potentiation of the side effects of digitalis. You may have dysarrhythmias, most of them being tachyarrhythmias. You may even have torsade de pointes. You may have ventricular fibrillations. You may have ventricular tachycardias. In the neuromuscular system, you may have malaise, weakness, which will often progress to respiratory failure, paralysis, even ileus. You may have fatigue. You may have hyporeflexia, especially in severe cases, but generally your deep tendon reflexes will be present. You may have cramping, you may have paresthesia, paralysis, rhabdomyolysis. In the GIT, you may have nausea, vomiting, abdominal distension, and ileus. In the renal system, you may have increase in ammonium production, urinary concentrating defects. You may have metabolic acidosis, paradoxical aciduria, nephrogenic diabetes insipidus, and glucose intolerance in the endocrine system. How do we evaluate these patients? You want to do a serum electrolyte panel. You're interested in phosphate levels. You're interested in magnesium. You're interested in sodium. You're interested in chloride, and of course potassium. You also want to check for these electrolytes in the urine. You want to get your serum, blood, urea, and nitrogenous waste levels, as well as creatinine. Check for creatinine phosphokinase, which may be elevated, as well as levels of glucose, and do a urinalysis. Generally, your urine specimen will be positive for RBCs. If you do a formal urinalysis, you're going to see that there's myoglobin, which is often consistent with rhabdomyolysis. You want to do an urgent ECG for these patients. Remember that the findings on the ECG are rather non-specific, and then it's not really so sensitive, but you may see flattening of the T waves, which is usually one of the first signs that you're going to see. You may sometimes see inverted T waves, prolongation of the QT interval. This may be because of the U wave that is becoming so big such that it appears as if the QT interval has prolonged. You may get this prominent U waves, ST segment depression, prolonged PR interval, a decrease in the voltage, as been QRS complex widening, bradycardia, an AV block, sometimes tachyarrhythmias like ventricular fibrillation, ventricular tachycardia, the so-called torsade de pointes. I think I talked about this. You may sometimes get premature ventricular contractions. Like I said, the first sign that you may often see is a decrease in the T wave amplitude. This is following ST segment depression, sometimes even T wave inversion. You see the U waves, which are best seen in lead V2 and V3. And then when they enlarge, of course, they may look like T waves, and this may actually give you a false impression that there is a prolonged QT interval. So here's an ECG showing you features of hypokalemia. As you can see, there's a T wave that is showing up here, concentration of 3.9 milliequivalents. Here, when it's 2.7, the T wave is even beginning to flatten out. The U wave is increasing in amplitude. Here at 1.3, you even get some ST segment depression with these large Q waves, and this falsely prolonged QT interval. Again, as we can see here in V4, we have the U wave popping up here, and the T wave is flattening out, as you can see in these other leads. Here, as we can see, amplitude of the U wave here is increasing in amplitude, and of course, you can see it at the end of the T wave. Here's a picture of a patient that had an ECG, a 12-lead ECG of a patient that had hypokalemia. As you can see, the U waves actually become so prominent, especially in this V2 here and V3. These U waves become very prominent. You may even sometimes get some invasion of the T wave that you can see here in lead 2. Okay, even lead 3. So what's our treatment? What are our goals? We want to prevent any life-threatening complications such as an arrhythmia, any respiratory failure, or any hepatic encephalopathy. We want to correct the potassium deficit. I'll spend some time talking about correction of potassium deficit very shortly. We want to minimize any ongoing losses and treat the underlying cause. So remember, we want to consider replacing potassium in the following things. If someone has a concentration less than 3 millimoles, if they have a concentration between 3 to 3.5 millimoles and they are a chronic heart failure patient, or they have cardiac arrhythmias, or they are on digoxin treatment, or it's after a myocardial infarction, remember that you must replace potassium with caution, especially with those patients that have renal problems, because just little amounts of potassium that are infused in them can cause hyperkalemia, which can also cause problems for these patients. So there are formulas that you can actually use in terms of correcting the deficit of potassium, and one formula I want you to keep in mind is the one that's going to be using a lower threshold of 3.5. So you're going to say the lower limit of potassium minus the measured potassium of that patient multiplied by the weight of the patient in kilograms multiplied by 0.4. 0.4 is the constant. So if we're assuming that our lower weight is 3.5 because we're using a constant of 0.4, 3.5 minus the patient's potassium multiplied by the weight of the patient multiplied by 0.4. So each person has a daily requirement of potassium of about 1 millimole per kg body weight. And remember, 1 gram of potassium chloride will give you roughly about 13.4 millimoles of potassium. The molecular weight of potassium is roughly around 74.6. Here's an example. So suppose a patient is weighing 70 kg and has a serum potassium of 3. So what is their deficit going to be? So 3.5, which is our lower limit, minus 3, that's of course giving you 0.5, multiplied by 70, multiplied by 0.4, you're going to get 14 millimoles. So it means this person has a deficit of 14 millimole. And each day, a patient requires at least 1 millimole per kg. So 1 multiplied by 70 is 70 millimoles. So in that particular day, this person needs to be replaced with 84 millimoles of potassium chloride. But remember that 1 gram of potassium chloride is going to be equivalent to 13.4 millimoles of the potassium chloride. So if you want to change this to the grams of potassium chloride, you simply divide that answer by 13.4. So you get 6.3 grams of potassium chloride. So what does this mean? It means that if we give this patient 1 gram of potassium chloride, for example, this 1 gram is going to consist roughly of about 13 millimoles of potassium chloride. It's almost going to be close to replacing this deficit that they have. So what we're going to do is that we're going to get the 1 gram, which is the 13 millimoles, and we're going to add it to 500 mils of normal saline, and we'll run it over 4 hours in the first day. So remember, if we're giving 4 hourly infusions, remember that 24 divided by 4 is 6. So you're going to give this infusion 6 times during the course of the day. So it means you're going to give a total of 6 grams, which is roughly translating to 80 millimoles, which is close to this requirement that they need, or the total number of millimoles that they need in a particular day. I really hope that makes sense. So it's such that the next day we're going to be checking this person's potassium and calculating this again. Remember, you should also be checking at regular intervals, doing your ABGs at 4 hourly intervals, or even much closer if this patient is actually even symptomatic. So remember that potassium replacement is rather gradual. In the patients that are stable and have mild hypokalemia, for example, those that are above 3 millimoles, so 3 to 3.5, these that can tolerate oral intake, then you should replace it with oral intake. So advise them to take foods that are rich in potassium, like fruits, dried vegetables, and even dried fruits. Then, as well as salt substitutes or potassium supplements. Those that have severe hypokalemia, you give them potassium chloride. So remember that the maximum recommended amount of potassium chloride that you can ever add to 500 mils of normal saline is 40 milliequivalents, or 40 millimoles. And this has to be given over 4 to 6 hours. That's if you're using a peripheral line. Never should you infuse it faster than 20 millimoles per hour. So in 1 hour, you shouldn't give more than 20 millimoles, unless if the patient actually has an unstable arrhythmia, or if you think that cardiac arrest is imminent, then you can give this 20 millimoles in about 20 to 30 minutes. If a more aggressive correction is actually needed, you can administer the potassium chloride in a central line, but the infusion again shouldn't exceed 20 millimoles per hour. Make sure that your patient is on constant ECG monitoring. And in most cases, remember that magnesium and potassium, quote unquote, are married. So if the patient has needs to replacement with potassium, more or less they're going to need magnesium replacement as well, even if the concentration of magnesium is normal, because magnesium is going to activate the sodium potassium ATPase, and this is also going to promote cellular uptake of potassium. So magnesium, about 20 to 60 milliequivalents over 24 hours, may be added to the infusion to optimize the reabsorption of potassium and also to protect against the arrhythmic effects of hypokalemia. So we add 20 milliequivalents of potassium chloride together with 2 grams of magnesium sulfate in 200 ml of normal saline, and we can actually let it run at 100 ml per hour, so over 2 hours. So we should consider replacing magnesium in patients that have severe hypokalemia. So what's our practical guide? So if, let's say, we have a patient with severe hypokalemia that's less than 2.5, of course this is a life-threatening thing, so you consider your ABCs. You replace the potassium with potassium chloride, 10 millimoles per hour if you're giving it via a peripheral line, or 20 millimoles per hour if it's via a central line. So we give 10 millimoles of potassium chloride in about 50 to 100 mils of normal saline, and this runs over 3 to 4 hours. Remember that you shouldn't add more than 40 millimoles of potassium chloride to a single liter of IV fluids, and you shouldn't add more than 10 millimoles being given per hour. Then do not just add the potassium chloride and then just infuse it. Make sure that you actually mix it evenly. And you should actually invert the bag of normal saline actually about 10 times. Remember, about 10 millimoles of potassium chloride will increase your serum potassium concentration by 0.1, and your goal is to actually reach 3.5 millimoles. And remember, these patients, if they are hypovolemic, remember dehydration is going to stimulate your renin-angiotensin-aldosterone system, and this is going to stimulate reabsorption of sodium at the expense of potassium. So if this patient is dehydrated, you want to aggressively address that. Make sure that they're not hypovolemic. Avoid giving them any fluids that have dextrose in them, because this may stimulate insulin to be produced and potassium to actually shift into the cells. And do check the magnesium levels and replace them with magnesium. So give 2.5 grams diluted in 50 to 100 mils of normal saline over 30 to 45 minutes in those that have severe, even intractable hypokalemia. And remember, this also helps maintain intracellular potassium levels. If the phosphate levels are low, you may need to use potassium phosphate as opposed to potassium chloride. So this is given at 2.5 milligrams per kg. You're going to change them to oral supplements and maintenance IV replacement once your potassium concentration is greater than 3.5, but make sure that you closely monitor their levels and you treat the underlying cause. If they have moderate hypokalemia, that's between 2.5 to 3.5 millimoles, generally this is not life-threatening, so you can actually replace it orally if there's no contraindication. Make sure you treat the underlying cause. Oral therapy is generally much safer, and the degree of potassium depletion does not correlate well with plasma potassium. Remember that. So potassium chloride is usually the preparation of choice. You can use Kalium Duro. That's about 1 Duro is equal to 10 milliequivalents of potassium chloride. You could also use potassium chloride syrup, 1 milliequivalent per mil. Remember that Kalium Duro is about 750 milligrams orally 3 times a day for 2 to 3 days, or potassium syrup 15 to 30 mils 3 times a day. And remember also that 10 millimoles of potassium chloride syrup is going to give you roughly about 20 milliequivalents of potassium. Slow K can be given, which is what we use in our setup here, 600 milligrams 3 times a day. And remember that 1 tablet of Slow K is going to be giving you around 8 millimoles of potassium. In terms of IV therapy, for those that have severe hypokalemia or those that are unable to take anything orally, we can give it via IV. Remember that your maximum infusion rate, if you're giving it in the peripheral veins, is 10 milliequivalents per hour. 20 milliequivalents per hour if you're giving it via a central line, and remember your infusion should never exceed 20 milliequivalents per hour, unless if there's paralysis or some malignant ventricular arrhythmias or cardiac arrest is imminent. So keep in mind that the total body potassium is roughly 50 milliequivalents per kg, and only a small fraction of it actually is in the extracellular space. So don't be lost into trying to actually struggle to replace this potassium by giving this patient a lot of milliequivalents of potassium chloride and then watching it slowly climb into the normal range. Because if just a small shift of potassium comes from those cells and moves into the extracellular space, it may actually cause problems for the patient. So like I told you, patients that have bad kidneys, you can actually cause problems very quickly. So to get the potassium rise by 1 milliequivalent, you only need about 100 to 200 milliequivalents of extra potassium. Complications of this include rhabdomyolysis due to muscle ischemia, rebound hypokalemia. And remember, if you aggressively replace the potassium, especially those that have hypokalemia that is secondary to transcellular shifts, then that potassium inside the cells can also shift back outside into the extracellular space, and this will cause rebound hypokalemia. Sometimes you may have some concerns with patients that have distributive hyperkalemia, especially in periodic paralysis. So the maximum dose of potassium replacement in these patients should be about 90 millimoles in 24 hours. Sometimes recall that a familial channelopathy with a periodic hyperkalemia can also cause periodic paralysis, and symptoms are actually less often severe but more frequent in hypokalemic periodic paralysis. Another complication is cardiac arrest. So to end this lecture, what's our disposition? So you want to admit patients that have moderate to severe hypokalemia. You want to admit those that have acid-base abnormalities, those with arrhythmias, those with digoxin or digitalis toxicity, those with profound weakness with impending respiratory failure, rhabdomyolysis, even hepatic encephalopathy. Those with potassium levels less than 2 millimoles, these should actually be in the ICU. Patients with mild hypokalemia, 2.5 to 3.5, those without any symptoms like ECG abnormalities, profound muscle weakness, ileus, or even other effects, these can actually be discharged with close follow-up to recheck the labs after about 2 to 3 days. That's about 48 to 72 hours. If they are on supplements especially, counsel your patients to take foods that are high in potassium, dried fruits, nuts, avocados, wheat germ lima beans, vegetables like spinach, broccoli, cauliflower, beetroots, carrots, even fruits like bananas and kiwis. So you want to decrease the dose of any diuretics that are potassium wasting or substitute them with potassium sparing medication. Then of course replace the potassium with about potassium chloride 20 millimoles orally 4 times a day to prevent any hypokalemia. I really hope you enjoyed this lecture on hypokalemia. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.